So now we'd like to open up the floor to questions from the audience. After we've heard questions from people in the room, we will open up the phone lines. Please state your name and affiliation before asking your question, and I will restate the question so people on the phone can hear.
Hi, Neil Osterweil with Frontline Medical News for Dr. Stewart. A couple of questions, please. One is, you didn't go into the details, I know it's a short presentation, about the adverse events. Peripheral neuropathy is a big problem. What with, at least with bortezomib? So what was the instance of that?
There was no increase in peripheral neuropathy in the triplet combination, confirming that Kyprolis does not cause that side effect.
Mm-hmm. Okay. And then there was a question about your comparator. You were using Lendex. Would you look at it against bortezomib Lendex?
There is an ongoing phase 3 trial looking at Kyprolis dexamethasone versus bortezomib or Velcade dexamethasone. It's, I think it's already completed accrual, and we expect results next year. It's a head-to-head comparison.
All right, thank you.
Caroline Helwick, ASCO Post. Dr. Stewart, so unprecedented, that's a big word. What are the other, what are you comparing that to? What's been shown before?
So in this same population of patients, this is patients who have relapsed 1, 2, or 3 times. The best result ever reported before with any combination of chemotherapy was about 19 months, with a very similar cocktail of bortezomib, thalidomide, and dexamethasone. But on that study, not only was the time free of disease shorter, given that we're cross-comparing 2 different studies, there was a lot of dropout due to toxicity. So I think this is unprecedented. We've never seen this duration with this side effect profile. So it's, somebody else mentioned this. So I personally think this is the standard of care at relapse in myeloma as of today.
What was the name of that study you just referred to?
Endeavor.
Peter Dropper, Biotech Strategy blog for Dr. Stewart. Could you talk a little bit about the cardiac toxicity problems we've seen with carfilzomib and what you saw in your study?
Yes, there's been a lot of speculation about this, which is why it's been so encouraging to see the results finally of a true randomized clinical trial. I would correct the terminology. I'm not sure there is a significant cardiac toxicity to Kyprolis. What we saw in this study, and I will go into detail about this tomorrow because people are very interested, what we saw was a slight increase in all-grade cardiac failure compared to control by, I think off the top of my head, it was 6% versus 4%. And for grade 3 or higher, 3% versus 2%. There were more deaths from cardiac failure in the control arm than there were on the triplet combination, even although there was only like 3 in one arm and 2 in the other. So I think this, to some degree, puts to rest some of these concerns which have been raised anecdotally. Sorry, one follow-up, just so I'm not, I want to disclose all the issues. There was an increase in hypertension in the triplet combination. So I think that does speak to some endothelial interaction with this particular compound. So hypertension was higher, 14% versus 8% in the triplet combination.
Michael Smith, MedPage Today. Dr. Alvarnas, you concluded that the implication of the trial is that people with HIV should not be excluded from clinical trials. And I'm wondering, does your result just refer to clinical trials, or is there an impact on clinical practice?
I think both. I think that with respect to clinical practice, patients with HIV infection and controlled HIV infection, so that's the qualifier, should be receiving transplants as a standard of care. And then I would say the second part of that is that as we look forward to the future, that this patient population not be a priori eliminated from participation in transplant trials.
Ed Sussman, MedPage Today, for Dr. Moskowitz. I may have missed this. What was your survival, median survival in your patients in this study?
So the median survival is not reached on either arm. It's in the mid-80s at this point. So the results of the trial in itself are quite good. Remember that the median survival of these patients with a stem cell transplant fails is approaching 4 years now. Median survival of a patient in remission at 2 years after a stem cell transplant is, in theory, indefinite.
So let me make sure that I got this straight. So it's, your median survival hasn't been reached, but you're up to 80 months. Is that?
No. The median follow-up, you mean, in the
Yeah.
study?
Yeah.
The median follow-up is about 28 months.
Okay.
Next question, Alice, did you?
Just 2 points of clarification. Dr. Alvarnas,
Yes.
your remarks refer to patients with HIV-related lymphoma.
Yes,
Everything you said.
yes.
Okay. Dr. Moskowitz, what did you say median survival of patients in remission at 2 years after transplant?
So in patients in remission after a stem cell transplant for Hodgkin lymphoma, those patients have the same survival, in theory, of patients without Hodgkin lymphoma. Those patients are almost all likely to be cured.
Dr. Martin and Dr. Mateos, can you speak to elotuzumab? That's another antibody in myeloma, but it's a different,
Yeah.
works in a different manner. And there's a study here showing a 33-month PFS in a very small number of patients, but pre-treated.
Yeah, you are right, but elotuzumab is also a monoclonal antibody, effective in multiple myeloma patients, but the target on the myeloma cells is completely different because the monoclonal antibodies, daratumumab or SAR, that Dr. Martin presented, targets to the myeloma cells by binding to CD38, that is an antigen present in the surface of the plasma cells. Elotuzumab, the target in the myeloma cells is CS1, that is other different antigen. Elotuzumab, single agent, didn't show any efficacy. However, as you mentioned, in combination with lenalidomide plus dexamethasone, resulted in a median progression-free survival of 33 months. And in fact, these results will be updated during this ASH meeting. But of course, we have to wait to obtain the results of the phase 3 trial that it has been completed, and then probably we will know the results during next year.
Well, just to follow up, Dr. Martin, would you add this to the blockbusters?
Well, so my definition of blockbuster is really the agents that have single agent activity. However, lenalidomide has really bolstered the response to elotuzumab for sure. And what Dr. Mateos was just saying, there's 2 randomized trials that have completed accrual, one in newly diagnosed patients and one in relapse and refractory patients. And probably in 2015, we're going to get the data from the relapse and refractory. And it's similar to the Aspire trial, that it's lenalidomide and dexamethasone versus elotuzumab, lenalidomide and dexamethasone. And the Aspire trial just set the bar. And it's a high bar, and we'll see. And if the 33 months comes out and is true like they saw in the smaller phase 2 study, then they'll hit the bar. It'll be great. So the combination, I say, is a blockbuster.
Ted Bosworth, Clinical Oncology News for Dr. Mateos and Dr. Martin. You show the results with fairly small numbers of people, and yet you're very enthusiastic about this drug. I write for community oncologists. I was wondering what this means to them. They should be looking for certain patients to put into trials that they can get them into, or is this something that they should be thinking about in the next year when the drug is more mature?
Yeah. Concerning the trial, I presented this was a phase 1b trial, just to know if daratumumab could be combined with the different backbone treatments in newly diagnosed myeloma patients and also in relapsed and refractory myeloma patients. I agree with you, the number of patients is very small, but we have demonstrated that the combination is feasible. And so the next step is to conduct phase 3 randomized trials in which the different backbones are going to be combined with the backbones plus daratumumab. And in fact, VMP plus minus daratumumab will start next year. VTD plus minus daratumumab will start also next year. And probably Pomdex plus minus daratumumab also will start.
So in terms of the community oncologists in clinical trials, as Dr. Mateos just said, it's going to be tested in frontline, in the early relapse patients, and in the multiply relapse patients. There'll be clinical trials, and it is one of the most exciting agents. So yes, to refer them to a clinical trial only makes it faster for us to get these drugs to, to fruition and to FDA approval or approval in Europe. So yes, we would encourage them to send patients for the clinical trials. Most of the time, the patients are calling us. The patients know very well because of you guys and everything, which is great. The trial that we ran, we finished that trial in record time. It was like 9.5 or 10 months that we finished the trial. And literally the docs on the line for getting a spot for the trial, we were fighting with each other. Well, no, I got a patient. No, my patient was first. No. So yes, this is where we're at with this.
Walter Alexander for Doc Guide for Dr. Stewart. Just a point of clarification. With the overall survival, you called it a favorable trend, and it was .018. What was the standard for significance?
The pre-specified stopping p-value was p is 0. It's on the slide, 0.005. So we didn't cross that boundary for stopping. I think there's still some instability in the curves. So at this time, it would not be considered statistically significant, according to my statisticians.
Isn't that a very high standard?
I think that's pretty typical in these studies, since the curves can change over time, that you set a high bar for early stopping. But we're encouraged by the trend that we're seeing.
Charles Bankhead, MedPage Today. A question for collectively the myeloma studies. Are there any potential problems with putting these blockbuster, unprecedented type drugs up front, as you're talking about? If it doesn't work, or if it works for a little while and then fails, are there some potential downsides to moving it higher up?
So in cancer medicine, there's really no example where you try to save your best medicine for later. And so in cancer medicine, we always try to take our most active agents and put them up front to see if for the odd chance that we may be able to either cure people or make the remission durations just last longer. So we keep doing that. We keep moving our best drugs as frontline. So I don't think that saving it in the back pocket is not a strategy that we tend to move forward.
Lynn Peterson with Trends in Medicine. Dr. Stewart, I'm a little confused on the overall survival, because when is the final overall survival data? And if there is no benefit in overall survival, then what does that say about this?
Yeah, this was an interim analysis. It was done when there were 60% of the required events for final analysis. So it will be some time until we're able to look at overall survival. One of the issues with I think for all the cancers we talked about today, but for myeloma in particular, survival has become much longer recently, and there are very effective therapies when people relapse. So it's been quite difficult to show overall survival advantage because of the confounding effects of adding different drugs like the antibodies you just heard when people come off the trials and go on to other treatments. But we will have a final overall survival analysis, but probably not for another maybe 24 months. I don't know when it will come, but we're only at 60% of events.
So this will be the last question from the room.
Which was the second part?
And if there is no overall survival benefit?
One can't speculate. I don't think it changes the primary endpoints and the overall benefit we saw from this study. This cocktail, one thing that wasn't brought up earlier was that this regimen has also been studied already in newly diagnosed patients, and is probably the most effective regimen ever applied in newly diagnosed patients. So this is here to stay, I think, despite what the overall survival result this study shows.
Okay,
and we hope it will be made widely available through the regulatory authorities soon.
Go ahead.
Nick Mulcahy from Medscape. Question for Dr. Kahl. Would you comment on the multiple myeloma studies and their potential blockbusterness?
Blockbuster is a big word, obviously. So with regard to the two anti-CD38 monoclonal antibodies, obviously it's very, very early. So probably too early to plant the victory flag in the ground. Having said that, the early data is very promising. It totally justifies all the comments that were said earlier about bringing these drugs forward aggressively, moving them into frontline, completely justified. Dr. Stewart's study, I think, will establish a new standard of care in this patient population. I'm confident that that's a true statement. So,
Actually, I wasn't talking about Dr. Stewart, the multiple myeloma studies.
his was a multiple myeloma study. Yeah. Okay. So we need to open up the phone line for questions now. Operator, are there any questions on the phone?
I do.
No questions? Okay. Right back here.
Thank you. Alex Goodman, the ASCO Post. Dr. Kahl, could you please put Dr. Kahl, could you please put both of the lymphoma studies into context? It wasn't clear to me how often HIV-related lymphoma occurs, like in how many patients, percentage, and also what do these two studies mean to our readers? Something we can, comments we can say. Thank you.
So having HIV that's even well controlled does increase one's risk for developing non-Hodgkin's and Hodgkin lymphoma. And it is a true statement that in many centers, HIV positivity is exclusionary for receiving stem cell transplant, which is the only potentially curative strategy for the patient population that was studied today. So I think the data that you saw today will change standard practice at centers who currently exclude HIV positive patients. So I think the impact of that is large. With regard to the Athera trial, this is the first study that has shown a significant benefit for a post-transplant strategy in any kind of aggressive lymphoma. I think with the Athera trial, the big question in my mind is the application of the maintenance brentuximab vedotin just delaying the inevitable relapse, so the patients will still relapse just later, or has the brentuximab taken patients who are destined to relapse and has turned them into a cured patient? We don't know the answer to that question. That will become apparent with more time.
Thank you very much.
Yep.
I think we have time for one more quick one, and I saw one right over here. So.
To go back to myeloma again, at this meeting there's going to be a debate over whether stem cell transplantation still has a role in treating myeloma given the effectiveness of these drugs. Where do you stand on this issue? Do you think that eventually it could be eliminated?
I think eventually it will be eliminated, but it will take some time. There are 2 randomized trials we're eagerly anticipating probably next year, which are looking at re-examining the role of autologous stem cell transplant in this disease. In the New England Journal of Medicine a couple of months ago, an Italian study seemed to reconfirm its value. So I think for now, stem cell transplant will be here to stay for a while, but hopefully in the next 5 to 10 years, as these drugs you heard about today get added to frontline therapy, the role of transplant will be diminished.
Okay, this concludes this press conference. I want to thank our presenters and thank everyone for attending.